Hello and welcome to this lesson, keratitis. Have you ever encountered a patient with severe eye pain and wondered, is it conjunctivitis or something more serious? So in this video, we are going to talk about keratitis, something more serious. So let's dive into the world of keratitis and learn how to differentiate and manage it effectively. So first, let's understand what is keratitis. Keratitis is inflammation or infection of the cornea, and cornea is a transparent dome-shaped structure in front of eye which consists of different layers, and in this picture you can see different layers of the cornea. So here we have epithelium, Bowman's layer, after that we have stroma, dual layer, decimetal layer, and endothelium. So these are different levels of the cornea, and in the picture, in the above picture here, you can see a patient with keratitis. So causative conditions are something like bacteria, viruses, fungi, parasites, or even allergens can cause keratitis. And this disease can be mild, severe, or moderate, and it can lead to permanent vision loss if it's not treated properly. So there are common symptoms that you can see in the case of keratitis. For example, patient may have eye pain, photophobia, blurry vision, and redness, and you have to be capable of differentiating redness in the eye from other eye conditions that can cause redness in the eye. So first, let's talk about bacterial keratitis. The most common cause is contact lenses, and this is due to the poor hygiene of contact lenses. And the common bacteria causing bacterial keratitis is Pseudomonas aeruginosa, Staphylococcus pneumonia, Varicella and Enterobacter group of bacteria. And in this case, in case of bacterial keratitis, the bacteria are going to penetrate and infiltrate the corneal epithelium, leading to stromal inflammation and necrosis, and this can lead to corneal ulceration. So the presentation would be acute onset of pain, redness, decreased visual acuity, photophobia, and purulent discharge. And note the common symptoms of bacterial keratitis and bacterial conjunctivitis. So in case of bacterial conjunctivitis, we also have redness and purulent discharge, and we can have acute onset of the disease. So you have to be capable of differentiating between these two diseases, because bacterial keratitis is a much more serious condition and can lead to vision loss. So we can have corneal findings with central or peripheral white infiltrations, and this can be with or without visual with epithelial defect, which can be visible on fluorescent staining. We are going to talk about that in upcoming slides. Also, the diagnosis can be done with a slit lamp with fluorescence staining. So on the fluorescent staining, you are going to see epithelial defect, stromal infiltration, corneal thinning, or even perforation of the cornea. And if you scrap the cornea, you can find and culture that for gram stain and culture of the bacteria. So the treatment should be done immediately and should be done with broad spectrum topical antibiotics. And the best choice that we have here is fluoroquinolone, but it can be adjusted, of course, after the result of the culture coming. And note that you have to avoid the steroids until the infection is controlled. So now let's talk about viral keratitis. So in case of viral keratitis, we have two main viruses, Herpes simplex virus, which is the most common cause of viral keratitis, and also we have Varicella-Zoster, which is associated with Herpes-Zoster ophthalmicus in case of Varicella-Zoster. So the presentation with Herpes simplex virus is going to be unilateral eye pain, redness, blurry vision, but here note that we do not have purulent discharge, and on fluorescein you are going to see dendritic ulcers. Also, the patient is going to suffer from reduced corneal sensation, and it is very important diagnostic clue. In case of Varicella-Zoster, we have above symptoms, and it is also associated with vesicular rash on V1 branch of trigeminal nerve, and this is called Hutchinson's sign. So here in this picture, you can see the Hutchinson sign in patients who is suffering from Varicella-Zoster and Herpes-Zoster ophthalmicus. And for the diagnosis, you use a slit lamp exam with fluorescent staining, and what you are going to see, which is very characteristic, is dendritic ulcers. Also, you can do PCR or viral culture if needed. So the treatment for herpes simplex virus is going to be topical antivirals like ganciclovir, or oral antivirals like acyclovir, and avoid steroids in case of herpes simplex virus because it can complicate the situation. And for the Varicella-Zoster is oral antiviral like acyclovir or valcyclovir, and also topical lubricants. So now let's talk about allergic keratitis. So allergic keratitis is due to hypersensitivity reaction to environmental allergens, and it is associated with other atopic conditions like asthma. So in case of allergic keratitis, we have allergens triggering mast cell degranulation. They release histamine and causing inflammation. So the presentation would be severe itching, burning sensation, redness, photophobia, and on the you are going to see papilla on the limbal surface of the eyelid, which is called Horner-Trantes dots. Also, in case of allergic keratitis, shield ulcer can happen in severe cases, and we can have corneal scarring in chronic cases. So the diagnosis is based on clinical history and examination, but you have to rule out infectious causes if we have epithelial defects. So what would be the management? Avoid allergens, topical antihistamines, and mast cell stabilizers like olopatadine. The patient have to use artificial tears for lubrication, and in severe cases we can use topical steroids, but this has to be done on ophthalmology guidance. So here you can see different presentations for different types of keratitis. In case of bacterial keratitis, you can see the fluorescein staining is positive. Also, you can see hypopyon in the corneal region. Also, in case of viral keratitis, you can see dendritic lesions. In case of fungal keratitis, you can see white gray lesions in the cornea. And in case of protozoal keratitis, which we did not discuss, you can see ring-shaped infiltrates in the eye. So what are the mistakes that a student can make when they are facing keratitis? Number one, not performing fluorescein staining. So a student often miss corneal epithelial defects or even ulcers because they skip fluorescein exam. So this is the number one mistake that you have to avoid. Another mistake that students can make is confusing conjunctivitis with keratitis. So mistaking conjunctivitis, which is a superficial infection, for keratitis, which is a deeper involving cornea infection, can be drastic. So there are key differentiation points that you have to note. The patient who is suffering from keratitis can have pain, photophobia, or visual changes, but these are the symptoms that do not exist in case of conjunctivitis. The third mistake that you can make is overprescribing a steroid without confirming the diagnosis, and using topical steroids in case of suspected keratitis without ruling out an infectious etiology like herpes simplex virus can be drastic and can cause worsening of viral keratitis. Another mistake is neglecting contact lens history because the patient might be suffering from Pseudomonas infections and bacterial keratitis. Another mistake is delaying the referral to the ophthalmology. So here we have failing to recognize the severe cases, for example, rapidly progressing bacterial keratitis, fungal keratitis, or deep corneal ulcers that requires a specialist intervention. Another mistake is underestimating symptoms of herpes simplex keratitis, and these are due to the fact that the doctor is ignoring subtle symptoms like mild pain or recurrent episodes of redness, and this can be fatal. Also missing reduced corneal sensation, which is a hallmark for herpes simplex keratitis. Another mistake that you can make is inadequate patient education, not advising patient on proper contact lens hygiene, or need for follow-up care, which can lead to repeated infection or delayed healing. So now let's talk about mistakes that you can make in case of keratitis. Number one is failing to differentiate between types of keratitis: viral, bacterial, and allergic. For example, mistaking HSV keratitis with dendritic ulcers for bacterial keratitis with corneal infiltration. Number two is ignoring the importance of risk factor. For example, not associating Pseudomonas with contact lens wearers, and missing the trauma history in patients who is suffering from fungal keratitis. Number three is overlooking the classical exam clues. In case of HSV keratitis, we have dendritic ulcers on fluorescein staining. In case of bacterial keratitis, we have pain, redness, purulent discharge, and infiltrations. In case of allergic keratitis, we have itching, limbal papilla, or Horner Trantes dots. And this is the third mistake that you can make on the exam. Number 4 is incorrectly prescribing steroids. Again, note that in case of fungal or viral keratitis, steroids are contraindicated. Number 4 is confusion between keratitis and uveitis, because both of these diseases are going to present with photophobia. Number 5 is underestimating the role of the diagnostic tools, not mentioning fluorescein staining or corneal scraping for culture in bacterial keratitis, failing to discuss the PCR or viral culture when you are suspecting HSV keratitis. So these are the symptoms, these are the mistakes that you can make in the exam, and you can lose points on these kind of mistakes. So here we have two classical scenarios that you might encounter in the exam. So if you can answer these questions, leave the answers on the comment section. In first case, we have a 25-year-old contact lens wearer presented with severe eye pain, redness, and corneal infiltration. So what is the diagnosis? And in question 2, we have a 40-year-old patient who is presented with recurrent episodes of redness, mild pain, and dendritic ulcers on fluorescein staining. So you have to tell me what is the diagnosis. So what are the takeout points? Always perform a thorough history and a slit examination, a slit lamp examination. Fluorescein is essential for diagnosis, and timely treatment can prevent vision loss. And know the contraindications for steroids in infectious causes of keratitis. Thank you for watching.